On behalf of PACO Foundation, this is Dr. Alfonso Tafur. Thank you very much for joining us today on a journey to eliminate preventable thrombosis. I am glad to have Babak Sherry Miller, a former interviewer for in South African journalism, and the two esteemed professors that I love to share and have participated many times over already, to start sharing the position on what is it that we can try to do to improve this.
Thank you very much, Alfonso. I'm very honored to be talking to such esteemed guests. Gentlemen, greetings to you. Professor Alex Spyropoulos and Professor Joe Caprini. Professor Alex, I'm going to call you Dr. Spy. I'm told that's okay with you. I'm going to start with you, Professor Joe Caprini. Alfonso, Dr. Tafur has expressed frustration. I'm sure this is something you also share. Your life work has been basically getting to this point where we could have mandated preventative methods. Why are we not there yet?
Well, that's a very important and complex question. And I would say that part of the reason is that we have to go back to guidelines. And most people in scientific communities are very, they feel it's very important to follow guidelines because that is dictated by people who've studied the subject thoroughly and they put together studies and so forth. And so they look to guidelines. Now, the trouble with guidelines are that guidelines, and in this particular case, we're talking about patients who are at risk for thrombosis. Take a group of medical patients at risk for thrombosis, and you bring them into the hospital. And in the old days, you give everybody prophylaxis. Well, there would be a high bleeding rate, and there were some of those people that wouldn't really benefit from the prophylaxis. There are good studies that show that if the score is low, that the patients not only don't get a blood clot, but if you give them anticoagulants, it doesn't help. The guidelines haven't progressed to that point. And I'll just say one thing at this point, because naturally I've been involved with the Caprini Score for many, many years. And also, I can't tell you how thrilled I am to be in the company of my dear esteemed colleague, and I've known him from the beginning. And he's done this magnificent work on the medical side. And my hat's off to him. But Chest in 2012 finally decided that risk assessment was appropriate and said with a Caprini score, everybody with a score of over 5 is at high risk of thrombosis. That was in 2012. Now, as the studies went along, for example, in 2014, there was a study that came out in head and neck surgery that patients with a score of 5 or less had almost a 0 chance of thrombosis. So that early conclusion was wrong. But that conclusion was never amended when it came to the ASH 2019 guidelines, because at the time of the 2019 guidelines, we had 150 publications and a very well done meta-analysis where the author, Christopher Panucci, went back to the original authors of the study and got their databases and put it in, and clearly showed that patients with a score of lower than 7, not only didn't the prophylaxis do anything, but those patients weren't at high risk of thrombosis. Why that was omitted in 2019, I don't know, but still I see papers coming out where they're referring to the old numbers. And so I think that's one thing. The second thing is that, and I just like to highlight this and get this off my chest. Alex has done a tremendous job with all of these beautiful publications, and he's partnered with the anticoagulation companies to show the value of anticoagulation in patients at risk. And before COVID, if I'm not mistaken, Alex, there was over a 60% risk reduction in medical patients who had an elevated improved score and got prophylaxis. So you were able to show that specific population that was at high risk. Along comes COVID. Did you see all these studies in COVID? There's 1,000 studies in COVID. How many studies are on risk assessment in COVID? Well, we just found one, and I won't expose anymore, but the Hep COVID trial really had taught us a lesson, as did the Michelle trial, about risk assessment. So the other thing, and I'm sorry for the long-winded answer to this, but this is really critical. People haven't paid attention to risk assessment, and it's hard to collect these factors. And I can tell you, when you go in for surgery and you're in the holding area, they ask the questions. That's ridiculous. You can't ask those questions. The patients are worried about their surgery and whether or not they're going to survive and how bad it's going to be. I'll stop there.
Okay, thank you, Professor Caprini. Dr. Spy, Professor Caprini just led into that whole question and segment regarding COVID and how it's changed the landscape. Can you talk to us a bit about your experience with your international studies, what you've seen, and what COVID has done to this picture?
Yes, first I'd like to thank the organizers of this conference for their kind invitation. And I have to say, it gives me great pleasure and a big smile to be in front of, and I won't tell him that in front of his face, but Dr. Caprini was one of my mentors when I was a young investigator. So one of the reasons that I got into risk assessment very early on in my research career was due to Dr. Caprini's efforts, and he really spurred my interest. So Joe, a big hats off to you, and it's been a remarkable journey. I had to say that it's nice when the mentee all of a sudden, is talking to the mentor in this field. So, I think of risk assessment akin to our current political landscape. Okay, what we're seeing, at least in the United States, are extremes. We're seeing extremes of left, and we're seeing extremes on the right. And in the medical community, I think we've seen the same extremes. So on the one hand, very early on was this concept of universal thermal prophylaxis, right? And as Dr. Caprini said, I think we overreached using that, especially on the medical side. So by prophylaxing every medical patient on the ward, all right, what we did is we probably over-prophylaxed as many as 40%, 40% of non-high-risk medically ill patients and subjected them to the harms of bleeding, okay? That's on the one side. But I think, as Dr. Caprini eloquently pointed out, now we have the opposite effect, so that the guidelines are demanding such stringent criteria with respect to risk assessment that the medical community is confused, and it's almost like a deer in the headlight. Well, we shouldn't be prophylaxing all patients, but on the other hand, the guidelines are not helpful in helping to distinguish which, number one, VTE risk tools we should be using, and number two, how we should be using them. Okay, so in the absence of that, I think we're really kind of a deer in the headlight mode for many, many health systems, not knowing how to implement the wealth of VTE risk assessment that's out there. There's a wealth of data out there. We've made tremendous efforts in the last 10 years to, number one, develop these VTE risk tools in an evidence-based way, and number two, validate them externally. And as everyone tells you, the validation part is the hard work, right? It's easy to develop a score, but the hard part is can you validate them in external populations in multiple settings? And that's when the strength of the score really comes out. So we have this data. So now what we don't have is how to implement that. So there's two aspects of that. On the informatics side, we have very sophisticated informatics environments here in the US health systems. So the informatics really has not caught up with respect to the science of VT risk assessment and how to implement that. For example, at Northwell, it's only been in the last 2 or 3 years. And again, after Dr. Caprini gave a beautiful, beautiful keynote presentation, we finally spurned our IT leadership to implement both the Caprini score in surgical patients and the improved score in medical patients. But it took Dr. Joe Caprini coming to our health system, giving, again, a keynote presentation, a call to arms that finally mobilized our health informatics community. So that's one example. And then the second example is really a shout out to guidelines to be more pragmatic and physician focused, okay? We're not gonna, and I'll give you a good example. We recently validated the improved DD tool in COVID-19 patients, okay? Undergone an external validation, and yet talking to the ASH guideline committee, their biggest quirk is that the tool was not developed in COVID-19 patients. And that's really a high price because, again, during a pandemic, what's more important is not the development of tool in a subset of medically ill patients, but is the tool valid in the COVID-19 subset population of medically ill patients? And the answer was it absolutely was. And yet all these major validation efforts did not make it to, for example, the most recent reiteration of the ASH guidelines. And that's exactly what Dr. Caprini is talking about. We're at a disconnect, right, between what the informatics environment can do in terms of tool implementation, what the guidelines are advocating for, in my view, a very nihilistic approach by not using individualized VT risk stratification, not helping to steer the clinician in one or another direction as to the importance of risk stratification, how to use the tool. And number three, the medical community, which is stuck in the middle. And I'll stop there.
Professor Caprini, short of cloning yourself and creating maybe 25 to 50 Joseph Caprinis to get in front of the relevant people and make this work, the Caprini score is being used in China. Europe is way ahead of the US. What is the short answer to how do we get patients the treatment that they need, the preventative care that they need? What is the short answer of how we get this done?
Well, I think that it's gradually occurring, you know, as these studies come out, and just a note, without the brilliant people around me, we would not have a score. I was at the right place at the right time. So it was kind of an accident that I sort of fell into this. So I just don't want people to think that this was just because of what I did. But the problem here is that we have over 200, the 234th article came out this Saturday on PubMed, and it's in over 5 million patients in all 6 continents. And there's some medical studies, but most of this is all surgical patients. And these investigators have figured out all over the world how to do that. And it's gradually sinking in. And so I see this process. An article, I just got an article to review in this Clot Aware section that we're invited to review articles. Finally, in trauma patients, they said that the Caprini score supposedly over 4 or 5 is high, but we dissected that and we found that as the score went up, we could tailor the prophylaxis and prevent these patients from having serious events and dying. And that's really the only other time that the orthopedists have done this is out of Northwell, where Alex's group with Professor Krauss has shown that, you know, everybody now is giving aspirin for everything. And they've shown that, yes, aspirin is very good for a certain segment, but when the risk goes up, you might want to use something more. So this is a growth trend. Now, and this is going to take years. I started the Caprini score in '86, getting together with a bunch of people. And it was never even in chest until 2012. And here we are in 2021. It takes years. So what I've decided to do is I'm donating all rights of I want the American Venous Forum to take over the Caprini score and develop an AVF Caprini score. And we have a big subcommittee now that's been meeting for a year and looking at all the risk factors and looking at all the aspects of the score. And eventually, and it's going to take a number of years, is that this will gradually be grown and grown and grown. And what I think is going to happen is that the American Venous Forum, if they're smart, and I'll do my best to make this happen, will get Alex right in the middle of the mix. Because when I met Alex when he was a little pup, it took me 15 minutes to figure out that he was going to be a superstar. And he's exceeded all expectations to now. And I'm hoping, and I will do everything possible to get the American Venous Forum to incorporate Alex into this ongoing process. And I'll just say one more thing. There's a vena cava filter that Laser Greenfield developed. And when he developed it, the company came to him and said, Laser Greenfield, we've got all these honoraria. He said, you're going to be making millions on the proceeds from your share for developing this. He said, no, I'm an academic surgeon. I will not do that. He said, but I want you to do 2 things. I want you to set up a database, and I have a nurse, Mary Proctor, and she will try to follow every single patient that ever gets a filter for life to see the effects. And number 2, I want you to take all that money you want to give to me and keep it in your company and improve this product. Continue to improve it, because if you don't improve it, it'll die. And that's the way I feel about what Alex and I are doing. This has to be continue to improve, and it's going to take an awful long time to see that happen.
So we have invited people to ask questions, and we do have a question from Jerry. He says, might I have benefited from an assessment when I went into the hospital overnight for pneumonia at age 62 and in great health and sent home to recover? And 1 week later stood up and through an embolism, it was life-altering. 2 years ago, I'm back walking 5 miles a day, and genetic testing was without any certainty said I was an anomaly. well, what can I do now to prevent another one? All my team doctors said I am at same risk as general population.
That's not true. So the fact that this patient had a previous event, at least when you look at the 7-factor improve tool, already he has points for getting a previous VTE, right? He has points for his age, over 60. If he's sick again, he'll get the immobility point. So he's already at risk of not only getting in-hospital thromboprophylaxis, but likely post-hospital extended thromboprophylaxis. And that's the point. The point is, the reason why it worked in a European health setting is because there was a national mandate under NHS to do so. We need something similar for the United States. We need a mandate, whether it be the Surgeon General, a call to action. But what's important is again, there's a few scores out there that have been extensively validated, to choose the 2 or 3 best validated scores and then make this some kind of national mandate to say, you know what, we need to use a score. It's not enough to say, well, I think this patient is at risk. No, this is now should be based on evidence. What is the score? What is the score threshold? If the patient is at that score threshold, does not have bleeding risk factors, that patient should get thromboprophylaxis, okay? So I think we need something like a national mandate, Surgeon General call to action, to really mobilize our medical community to move in that direction. Because as I mentioned, unfortunately, the guideline bodies are not, in my view, doing as much as they can to move the needle. And then to Dr. Caprini's point, if we have large national and international medical organizations such as the American Venous Forum, such as the International Society of Thrombosis Hemostasis, right? Such as the American Society of Hematology. I think those organizations really need to step up to really push these mandates forward.
You know, I have 3 things to say about this. The first thing I would like to say is that it's shocking. You saw Dr. Bullant present the data on the vaccines. And yet in this country, and I have I don't like politics. I don't like any of the politicians, but trying to get everybody to get vaccinated, is that such a bad thing? Of course, it's not a bad thing. So that's one thing. The other thing is that I'm a firm believer in history. And one of the reasons that the basis for the Caprini score, one of them was Dr. Maxwell Boro, a vascular surgeon from Seton Hall. And he did studies to show with venographic endpoints in 1981 and 83 that patients who had a history of a DVT and had a subsequent operation had a 66% chance of getting another clot. Those values have never been disputed. The numbers change slightly because we have more effective prophylaxis. But to the patient who asked that question, that patient is at very high risk if they have another procedure. And then another thing that just frosts me, and I have to bring it up right now, and I've seen hematologists say this: a person will have a clot in the past and then come in for an operation later, and they'll be sent to a hematologist, and the hematologist does all these markers, protein CNS, antithrombin 3, blah, 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 and says, oh, the markers are negative, the patient's fine. The patient's not fine. 80 to 90% of people that get blood clots do not have an identifiable marker that we can identify yet. And so that's another thing that's really disappointing. And I think that the final thing I want to say is to absolutely underscore what Alex said. And I think that that's really, really important. And it takes a long time. And, you know, that's, in a way, that's one of the bad things about free will and about, you know, freedom, is that there's certain things you shouldn't have freedom for because you're hurting yourself by not going along. And there's nothing more compelling right now than people who don't want to get vaccinated.
So in the current climate, with the lack of mandates, what would you say there's more onus then on the patient with their doctors to really look at how much at risk they are? Like with this gentleman asking the question, you really have to take ownership of, do I feel a certain way? Do I need to report this? What would you say to patients watching this?
Well, it's absolutely essential now that we're in a patient-centered era, that patients start taking ownership of their VTE risk. And I'm a member of World Thrombosis Day as part of the International Society of Thrombosis Hemostasis. And I think one of the key mandates globally is the fact that patients need to now get ownership, and they're more patient-friendly or patient-facing websites as part of these large thrombosis societies or cardiovascular societies that really speak in simple terms but easily understandable terms to patients to say, know your risk of thrombosis, ask your doctor, and what is to be done with that risk. And indeed, a lot of apps now are patient-friendly apps as well. So patients, and Joe, correct me if I'm wrong, they can actually download the Caprini Score. They can download the improved score, on their iPhones or others. So I think now it's become much easier for patients to advocate for themselves. And number two, large patient advocacy groups as well should advocate for patients. And then number three, I think as physicians, we need to do a better job. All hospital-based physicians should be aware, number one, of individualized VT risk assessment, and number two, receipt of appropriate thromboprophylaxis in discussion with patients. All the tools are there, they just have to be used.
So we have some more questions coming through. Linda was asking, is this a lack of implementation, a function of regulatory culture, hospital culture? Is it a fear of legal liability, risk of possibly changing things too soon? What would you change to move these adjustments more quickly? What paradigm shift could make a more significant change? She also goes on to say, we've seen from the vaccine issue, mandates are very hard to implement. How about making these evaluation processes something like, to be a center of excellence, you need to do these evaluation processes? Thoughts?
Well, there's a lot of good thoughts there, but the bottom line here is, and I would look to Boston as a poster child. In surgery, Boston had a high incidence of venous thrombosis, so they implemented a strategy using the Caprini Score. This is surgical patients. Using the Caprini Score, everybody had to fill out the score before they could sign their orders. And not only that, once they filled out the score, they would be told what prophylaxis will be given. And before they signed their orders, they agreed to that program. And there was always an opt-out feature. If the doctor thought for whatever reason that his patient was at high risk, he could opt out. He or she could opt out. What they did was they lowered the incidence of venous thromboembolism down to 0.1% at 30 days, including deaths on the general and vascular surgical service, from 2.2%. And they've mandated that since that time. And what was the mandate? Under five or under, you could give whatever you wanted in the hospital, but you got 7 to 10 days of prophylaxis. And this is another real sticky point for me. 7 to 10 days of prophylaxis if your score was 5 to 8, and you got 30 days of low molecular weight heparin prophylaxis if your score was 9 and above. And that's how they achieved that. And there was an 89% agreement, compliance with the 7 to 10 days and a 75% compliance with the 30 days. And that's Boston University, who takes care of indigent patients, made a deal with a drug company that every patient that needed the prophylaxis should get it regardless of their ability to pay. Now, in addition to that, and this is kind of an off-label comment, once you take money out of the equation, people didn't like giving injections, well, they could take one of the newer drugs too for 30 days. But if that type of a program illustrates that you can't have a protocol like we have, and you can't have an algorithm, but if it's not mandated, it really will not be effective. And you know, going back to what Alfonso showed us in the very beginning, the National Health Service from the United Kingdom, they mandated this risk assessment. They lowered deaths over a 2-year period. Without mandates, none of this is going to happen. And I also wanted to add one other thing, and that is the International Society of Hemostasis has agreed to cooperate with the American Venous Forum. And one of these days we'll get Alex in there too, because that's what it's going to take. And the Europeans and the Asians and the South Africans and the South Americans have done a much better job. And one of the reasons is that they've very quickly figured out if they used a risk score, and there's many roads to Rome here. It's not just improving Caprini, but there's the Padua score, there's a Geneva score, there's a Kucher score. There's many roads to Rome, but unless you do that, then you're not going to really be effective. And these countries very quickly figured out if they mandated that, they could save a lot of money, because a lot of people that didn't need it didn't get it. And those people that really needed it, they didn't have to spend money on treating them because they prevented the blood clots.
Leading from that, Dr. Spy, we're hearing the UK, China. How do we rate here in the US comparatively when we talk about Europe? Where are we in comparison?
I think we have, one of the advantages of our healthcare system is its uniqueness, right? But also one of the disadvantages is that we don't have a quote unquote national type health system to mandate things like make sense, such as VT risk assessment. Um, I think the way moving forward for the United States, which ranks somewhere in the middle, right? It doesn't have some of the highest quality metrics like a country, some of the Nordic countries do, like Denmark, you mentioned the UK and others. But of course, it has better quality metrics than other countries as well. So we're a middling country with respect to some of our quality metrics. And that's shown, for example, in the endorse registry, right, in terms of appropriate patients that do or do not receive thermoprophylaxis. In the United States, I think the way moving forward is really through the informatics route. And I completely agree with Dr. Caprini. The only way we can move the needle is by mandating at an informatics level, right? Hospital-based physician to use a particular score. Doesn't matter which one. But in order to move forward, right, with completing your H&P, with completing your order sets, with completing the notes, you have to formally risk assess a patient using the score, and many of the scores now can be automated. So we're conducting a clustered randomized trial in our very large Northwell system that 2 of the hospitals are using the improved tool that's embedded within the workflow of the physicians, and 2 other hospitals are using routine care. What we're hoping to do with this is to see if the embedded use of the improved score within the workflow tied to what we call order entry, right, an actionable item. It's not enough just to say what the risk is. What does that mean in terms of providing prophylaxis? So we're hoping that embedding the tool, making it easy to use, the tool auto-populates as much as it can lead to, number 1, an actionable item, which is receipt of appropriate prophylaxis, and then number 2, to lead to a decrease of adverse outcomes, namely thrombosis in appropriate patients. So in my view, moving forward, at least on the US side, we'll need some kind of a national-like mandate from the Surgeon General, sometime to call to action for individualized VT risk assessment. And number 2, to get the large informatics groups together to implement the scores at an EHR, electronic health record level. We can do that. We have the power to do both.
I wanted to add to that, there's no question that's the way to go. And to further do that, I've gotten to help get a grant for machine learning to look at these factors. You know, you can teach a machine to land an airplane and to drive a car. So what about taking all those elements and putting them together quickly? And the machine learning would be a way to do that and help us to further identify what's going on. And I'd just like to stop here for a minute, because there's a 10-ton elephant in this room. And that 10-ton elephant is risk assessment. There are risk factors. There's age, there's history of thrombosis, there's all of those risk factors. Sure, Alex has put them together his way, I've put them together my way, the other people put them together their way, but they're risk factors. And it's incumbent upon every doctor to look at every one of their patients and find out what factors they have that could lead to a bad outcome. Because the one outcome after surgery that's almost totally preventable is fatal pulmonary emboli that can be reduced to a very low level. And the thing is that's what everybody has to understand here. And how you get to Rome, as I said, that's another story, but you've got to look at those risk factors.
So, gentlemen, the magic word has been mandate. I know you just mentioned risk factors, but realistically, we don't have the mandate now. What do you see in the next, let's talk long term, next 2 to 5 years, and then the next decade? Are you seeing the mandate coming anytime soon? What would you like to see happen, and how fast?
Alex.
Well, I think this should be what we call a stepwise process, right? As Dr. Caprini said, it takes a long time to really move the needle with respect to a change in process in the medical community, right? We're a very conservative community by nature. So we've spent the last 15, 20 years, number 1, developing the scores, and number 2, importantly, validating the scores, right? What we need now is some kind of call to action, which is now starting. For example, World Thrombosis Day has placed a call to action to use some type of individualized VTE risk assessment score. It doesn't matter which one, but to formalize this. So that's the first process. The second process, as I mentioned, is that call to action. The third process is really now using our informatics colleagues and the wealth of information on the informatics side to start implementing the scores in real life to make this process easy. And then lastly, as more data gets in, hopefully this will also be looked at from the guideline bodies. So that's kind of the step process that I see evolving. And then the last point, which is very important, is simply the critical mass involving both patients and hospital-based providers to say, listen, what is this patient's risk for VTE? What is my, as a patient, risk for VTE? And what are you doing for that risk? So all these elements need to be placed together in this kind of stepwise fashion.
I wanted to add one more thing to that. I agree with that. That's clearly the way to go, and it's very beautifully articulated in steps by Alex. But there's another thing that can be helpful here. It's called nudges. Now, one of the states put out on its license that if you want to donate your organs, check this box. And they had a 40% compliance. Then they changed it and they said, if you don't want to donate your organs, check the box. They had an 80% compliance. So that was a nudge. Now, here's my concept for a nudge in this. You take Alex in medical patients or me in surgical patients, and you do the score in the background, and you follow patients for 90 days for a particular group of doctors or doctor. And at the end of the 90 days, then you'll see what they did or didn't do. Let them do whatever they want to do. And undoubtedly, you're going to see if they didn't do good risk assessment and if they didn't use appropriate prophylaxis for the length of time that it's appropriate, they're going to have higher values. And so you go to that doctor and you say, look, you didn't really meet the goals here. You've had too many clots and bleeds. Would you like to lower that? Now, why don't you do us a favor? For the next 90 days, just follow this protocol that we're going to put out. It's mandated. You can opt out at any time you want. And I would say that that's another short term. Alex was talking more about the long term. One of the short term things that you can do is to get people to do these nudges. And we have one of those programs going on now. And another nudge is, and this is something that Alex and I both firmly believe in, and it hasn't really been discussed yet. And I got to get this out on the table, because when a patient comes into the hospital and has a score, that's one thing. But during the hospitalization, the patient develops complications. They develop cancer. They need central lines. They perforate. They come in as a medical patient and have to go to surgery. You've got to have these as dynamic tools. So when the patient goes home, they ought to have a final improver, Caprini score, or whatever score you're doing, in order to find out whether or not those patients need protection long-term. And when the COVID people did all these studies and they came back and said, well, it's only 1.9% of people when they go home have a clot. And then came along the Michelle trial, which is Alex and it's rivaroxaban and so forth, said, hey, you can reduce the incidence 65% if you pick out those bad apples from the barrel.
Gentlemen, thank you so much. I can sense the passion. Thank you for your insight, your expertise. I'm being nudged out of this meeting room because we have to move on to the next segment. Once again, thank you so much. And we wish you the best with all your future work and studies.